Evening. My name is Karen Vastine, and I'm with the University of Vermont Health Network, and I am one of the project leads for the new mental health urgent care. Planning this program has been a wonderful collaboration, and we are all thrilled to be able to offer this new service to our community. As you all may know already, Howard Center will actually be in the lead and will be running this program in partnership with the Community Health Center, Pathways Vermont, and the UVM Medical Center. In a few minutes, you will be hearing from our presenters, which will include my colleague Maureen Leahy, who is the Administrative Director of Psychiatry for UVM Medical Center, and Charlotte McCorkel, who is the Senior Director of Client Services at Howard Center. I also want to acknowledge and thank our American Sign Language interpreters, Hannah and Lucia, who will be signing throughout the session. So I'd first like to review our format for tonight's webinar. So during the webinar, your audio, video, and chat functions will not be available. You may turn captioning on or off using your Zoom toolbar. If you have any technical issues during the webinar, you may send us your issue through the Q&A, and we will do our best to provide support. After the presentation that you will receive from Charlotte and Maureen, our panelists will take questions which may be sent through the Q&A at any time throughout the session, and you may ask your questions anonymously. We are recording tonight's webinar, and it'll be posted in the next few days at howardcenter.org. I want to take another minute just to acknowledge and thank all of our partners who are here with us tonight. And as you will see, as questions come up, I will be calling on my colleagues. So we have Joanne Wallace, who's the nurse manager with the Community Health Center. We have Sandy McGuire, who is the CEO with Howard Center. We have Katie Bork, who's the Director of Services for Pathways Vermont. Maria Moore, who is the Director of Development and Communications at Pathways Vermont. And Lisa Goodrich, the UVM Health Network Vice President of Psychiatry. So welcome. And now Maria Moore is going to take a few minutes to make some remarks on behalf of our partnership before our presentation begins. Thank you for being here, Maria.
Thank you, Karen. And thank you for all who have joined. On behalf of Pathways Vermont, I want to thank everyone who has worked over the past couple of years to make this mental health urgent care a reality. Seeing each organization bring its unique strengths and capacity to support the community and provide access to this needed resource is exciting. Pathways looks forward to offering peer support as an option and to building on the human connection of shared and similar experiences. This has been a true collaborative effort with opportunities for learning and sharing ideas across all our organizations. We appreciate Howard Center, UVM Health Network, and the Department of Mental Health's leadership and funding, and are happy to work with them and community health centers to make mental health urgent care possible. Thank you.
All right, and I will get us started. I'm Maureen Leahy, and I would like to echo my colleagues' welcome and thank you for taking time out of your evenings to learn about this new resource that's coming to our community. I'd like to spend a couple of minutes level setting and providing some context as to how we got to this point a week and a half away from opening the mental health urgent care located in Burlington. First of all, with regards to the incidence of mental health need in our community, it's important to note that nationally, we know 25% of the adult population has mental health needs. This is a number we've been able to replicate locally in looking at our primary care populations, where we see anywhere between 22% and 31% of people in our primary care offices with a mental health diagnosis on their problem list. Around about the summer of 2022, we were experiencing significant wait times in our emergency department at UVM Medical Center. On average, we were seeing 11 to 12 adult patients every day, and 1 to 2 children every day. We did have several days with more than 20 patients awaiting an inpatient psychiatric bed. This is a result of a continuum of care and a system of mental health care that results in an increased census in our emergency department if there are disruptions in care in other parts of the system. Around about the same time, the Department of Mental Health, UVM Medical Center, Howard Center, Community Health Centers, and Pathways Vermont all came together for a conversation about the problem and potential solutions. The two things we all agreed on is that the emergency department is not an ideal or therapeutic setting for patients experiencing a mental health crisis. And I always pause here and make a point of saying this is not to say that our doctors and nurses and mental health techs and other staff in the emergency department are not skilled and competent and compassionate with this population. But the emergency department location, the setting for it is not ideal for a therapeutic experience for somebody in a mental health crisis. The other thing we agreed on is that we needed to find an alternative to the emergency department. The emergency department has become a last resort stop for people because we do not have an alternative to the emergency department. Late in 2022, the Department of Mental Health issued a statewide request for proposal seeking programs that would provide a therapeutic alternative for this patient population. The same group of people, UVM Medical Center, Howard Center, Community Health Centers, and Pathways all came together for what has started a 2+ year long relationship and developed that request for proposal, submitted it, and we were awarded a portion of what we requested. I wanted to take a minute to explain a little bit about the resources that we currently have for crisis services in Vermont. So on the left of the slide, you can see our individual who is in crisis. And then the 3 icons to the right of that person are the, as of October 28th, the existing resources that will be available to that person. Right now, we have 988, which is a national phone service similar to 911 for medical emergencies that can be called, and you will reach a local resource that can help both in the moment intervening with the crisis and finding resources in your local community. The second one is mobile crisis, and in Chittenden County, and I know we may have some participants that are in other counties, but in Chittenden County, first call through the Howard Center is that mobile crisis service. And then we're adding the resource, which is the alternative to the emergency department. The person in crisis and or police, fire, and ambulances can access any one of those resources in any order. You do not have to move linearly through them. And adding the alternative to the emergency department, which is the mental health urgent care, allows for a place for the individuals to go who may not seek 988 as a resolution and may not feel that mobile crisis is the right solution for them. Admittedly, there's definitely overlap and not necessarily a right answer in all circumstances, but the addition of the mental health urgent care is key in providing this resource to the community. As you can imagine, bringing together 4 distinct teams into one team to provide care at the mental health urgent care has been a piece of work itself. We've had to manage all of the operational items that you can imagine would come with implementing a mental health urgent care. And then on top of that, figuring out how to work together as one unified team. In looking at those nuances, we're talking about differences in clinical workflows, we're talking about differences in emergency procedures, even differences in what holidays each agency recognizes. And as we've navigated those differences, this value statement has served as a guidepost for us in times where we needed to come together and find a solution. And I will take just a minute and read it so it can help ground us in the rest of our conversation this evening. Mental health urgent care will provide accessible, timely, trauma-informed care that is person-centered, equitable, and coordinated to meet the needs of each guest. And with that, I will hand off to my colleague, Charlotte.
Thanks, Maureen. It's really helpful to have that background information as we talk about operational details for mental health urgent care. So as Maureen mentioned, this is 4 agencies coming together. So Howard Center will oversee the program and manage operational and clinical programming. Community health centers will have an on-site registered nurse and then telehealth services. Pathways Vermont is providing peer support services, and we'll have 3 peer specialists on site at mental health urgent care. And then the University of Vermont Medical Center is providing the physical space, program funding, and other supports. And I'll talk more about that later on. In terms of operational details, mental health urgent care is designed to serve adults, people over 18. And our definition of crisis is very broadly defined. So if it's a crisis to you, it's a crisis to us, and we want you to access this service. In terms of the services provided, there is mental health clinical support in the form of brief intervention and crisis assessment, safety planning, medical care, assistance with medications, and peer support. And the location is at 1 South Prospect Street in Burlington on the Arnold 4 part of the building. Just today, a big sign went up on the building that says mental health urgent care. So if you're at 1 South Prospect Street, you can't miss it. And when you walk in the building, there's wayfinding to help people to Arnold 4. As Maureen mentioned, we were awarded a grant from the Department of Mental Health for part of the funding for mental health urgent care, and the rest of the funding comes from University of Vermont Medical Center operational funds as directed by the Green Mountain Care Board. So we have full funding for this program for 3 years. And the opening date is October 28th, just 12 days from now, a week from Monday. We'll be open at 9 a.m. As I mentioned, mental health urgent care serves adults, but it is a family-friendly space. So in the waiting room, there's a kids' corner, and we know that sometimes when adults are in crisis, they may have their kids or family with them, and we want to welcome them into the program, can support or distract the young people as we need to. And if kids are in crisis or someone under 18 comes in crisis, we will provide support and connect them to youth serving specific crisis supports. The hours for mental health urgent care are Monday through Friday, 9 to 5. And we intentionally designed this to be a weekday daytime program because we really wanted to make sure we had the staffing and operations at the start to support providing crisis care. Given the workforce challenges we have in our community and the vacancies in all of our partner agencies, we didn't want to overcommit to having evening hours or weekend hours when we weren't certain we could staff those. Those after hours times, of course, are the hardest shifts to fill. And so at least for the first part of our mental health urgent care operations, we will be operating Monday through Friday, 9 to 5, and we'll look at expanding hours from there. And we did have success in thinking about that daytime operations because we are almost fully staffed and able to provide all the services we intended to when we opened to on the 28th. As I mentioned, when someone arrives at 1 South Prospect, there will be very clear signs to assist with wayfinding to Arnold 4. And one of the advantages of being at 1 South Prospect is that we're hoping coming into that building where a number of different services are provided, including a lab and a pharmacy, will help to reduce stigma so that people could be coming into the building for any reason. And also that there can be a close collaborative relationship with the Seneca program and addiction treatment program and other mental health and medical related services that our mental health urgent care guests may also access. The program is a walk-in model, so we're not scheduling appointments of any kind. We are looking for people to walk in. And with that, there's no referral. So if someone already has a therapist or a medical provider, they're welcome to give a phone call to say, my patient or client may be accessing your service, and I have permission to share a little background about the concerns today, but that phone call is not necessary. Someone can walk in at any time between 9 and 5, and we will welcome them into the program and determine how we can support them and provide that support. In addition to support right at that time of crisis care, we will also provide follow-up services. So if someone would like to come back the following day for assistance with filling out a health insurance application, or help connecting to a therapist, or they were able to access crisis assessment the first day but want peer supports, they're welcome to come back until they connect to ongoing supports outside of mental health urgent care, or until they feel more stable with their mental health and overall well-being. And the services we're providing are voluntary. So someone can come into mental health urgent care and just access peer support through Pathways, or they can just access some case management support if that helps alleviate the crisis that day. So mental health support services will be offered by Howard Center in the form of crisis assessment, brief intervention, and safety planning. Peer support will be offered by Pathways Vermont. I talked a little bit about Howard Center offering care management or case management services, including referrals to different types of care for mental health services, but also community services and support. And then Community Health Center will be providing medical assessment and care. And aligning with our value statement, this care will be provided in a trauma-informed, suicide-safe setting as a therapeutic alternative to the emergency department. So right now in my work at Howard Center, I hear about a person or a family in crisis, and someone, a neighbor, a loved one, encourages them to hop in the car and they go to the emergency department because they don't know where else to go. And so mental health urgent care is designed to be exactly that place to go when someone doesn't have other supports to turn to that day, but they're really feeling badly and they're looking to access support. We have a staff of about 20 full-time staff. So we have crisis clinicians, peer specialists, care managers, registered nurse, navigators, and a team of supervisors and operational support. So it's about 20 staff in total, and we have almost all of those positions filled. So we're very excited about that. There are a couple remaining positions, and we're actively in the hiring process for those. As I mentioned, the program serves adults over 18 who are looking for immediate support or who are in any self-defined crisis. And as I mentioned, crisis can mean so many different things to different people. So we want to spend a little bit of time talking about specifically what we mean by self-defined crisis or mental health crisis. So this could be adults with complex or multiple diagnoses, possibly an intellectual disability, substance use disorder, traumatic brain injury. This could be adults experiencing a suicide crisis with co-occurring or complex medical conditions, or adults looking for peer support, or any combination of all of those above things. So there's nothing that feels too complex to welcome someone into mental health urgent care for support. That being said, if someone has a life-threatening condition like symptoms of a heart attack or a stroke, we do want them to access emergency department care. I was ahead of myself on that bullet there. Similarly, and I'll talk more about this in a little bit, if someone's incapacitated, meaning they can't manage their own body, they're falling over perhaps, or they're not able to communicate as they typically communicate, we can't serve them at mental health urgent care and would help them get to the emergency department if that's what's determined is needed, or to be with a safe adult who can help monitor their symptoms or condition. If someone is in need of inpatient psychiatric treatment, they do need to go to the emergency department to access that level of care. And part of that is to help maintain safety if inpatient treatment is needed. And part of that is for streamlining the inpatient referral process so that it's coordinated in our community. And while we welcome people who are voluntary coming into the program, again, on their own or with their support system, if someone is in crisis such that an ambulance is involved, an ambulance is required to bring someone to the UVM Medical Center emergency department. At the emergency department, the person will be triaged and treated there, but part of their discharge plan could be to go to mental health urgent care for follow-up support, or they could be advised that the next time they have a similar set of symptoms or a similar experience, they may go to mental health urgent care first. So I think of someone who may have a high level of anxiety and may be feeling some panic symptoms, and perhaps they're in public, perhaps someone called 911, and an ambulance takes this person to the emergency department. The emergency department can't refuse treatment or immediately direct them to mental health urgent care. They'll provide support and treatment there on site, but part of their discharge plan from the ER will be to get further support if that's needed at mental health urgent care, or the next time they're having those same symptoms to access mental health urgent care first. As I mentioned, there's no referral process. Anyone can walk in for services. And based on the physical capacity of the location at Arnold 4, we believe we can serve about 8 to 10 people at one time, and an additional 8 to 10 people could potentially be in the waiting room. There are no beds in this program, so it's not designed to be an overnight stay or where people are coming to sleep. As people are coming in, we'll be working with them on supporting them in that moment and identifying their needs for today. And if someone needs to come back the next day, we'll be helping them make a plan for what happens from 5 p.m. to 8 a.m. Similarly, if someone may not need to come back the next day, but they're not sure what will happen next, our team of staff will work with them on what their plan will be after their time at mental health urgent care. And that could be a referral to a crisis stabilization program or a respite program or accessing other community resources. And then people can come back the next day if needed. So I want to talk a little bit about the specific services offered by each partner agency to provide clarity about that. So community health centers will have a registered nurse on site, and then they will also have telehealth medical appointments with a medical provider. The medical care provided by mental health urgent care will be related to some sort of mental health or substance use need. So it could be that someone's coming in with quite a number of medications related to their mental health condition and physical health condition and wanting to talk about the side effects, perhaps, that maybe they're not able to access their prescriber to talk about that, but it's causing some distress or upset. It could be that someone is using IV drugs and has a wound from that drug use and is needing some care for that wound. So those are the sorts of medical services that will be provided by the registered nurse through a nurse assessment. And then a telehealth appointment can be arranged right there with a medical provider, or after someone leaves mental health urgent care, they can connect to primary care through community health center, or again, connected back to their ongoing primary care if they have that. At mental health urgent care, community health centers will not be prescribing controlled substances, including for medication-assisted withdrawal, and community health centers will not be starting psychotropic medications or psychiatric medications. So we will be very clear with signage right up front so that there are clear expectations that controlled substances will not be prescribed. And if someone is in need of medications for assisted withdrawal or for psychiatric medications, they will be connected to appropriate resources in the community. Pathways Vermont will have 3 peer specialists on site who will provide one-on-one support when that is wanted. And there's also a beautiful community room where Pathways will be providing support in an informal group setting to multiple people at a time, if that's what they would like. So peer support is an approach to relationships that recognizes each person is the expert of their own experience and fosters connection through shared or similar experiences. That's where the word peer comes into play, creating mutuality and mutual support, preserving autonomy, and looking to make meaning or exploring possibilities of what a crisis may mean for someone. And we're really excited that Pathways is providing peer support in this context, and really hoping that the guests who access mental health urgent care will not only access peer support in the moment, but will return to access peer support for follow-up care, and then may access Pathways' other supports in the community. Howard Center will be providing crisis assessment, brief intervention, and safety planning through our crisis clinicians. We have care managers who will be providing referrals to treatment, supports and other services, which could be other social supports in the community. And then UVM Medical Center is providing facility support for the physical location at Arnold 4. And there will also be consultation and coordination between the emergency department and mental health urgent care. So as I mentioned, if someone is in the emergency department and planning to come to mental health urgent care for follow-up care, and they give appropriate consent for follow-up and coordination, the emergency department providers may call mental health urgent care so that we can have a warm handoff with that person's care and treatment. Similarly, if there's a concern at mental health urgent care and we need to direct a guest to the emergency department, we will give a phone call so that they are prepared to welcome that person there as well. So as we mentioned, we have funding for 3 years for the full program for mental health urgent care. And so if a guest accesses telehealth through Community Health Center and meets with a medical provider, that specific telehealth visit will be billed to a guest's health insurance. And Community Health Center also offers a sliding fee scale. But beyond that telehealth medical appointment at mental health urgent care, the other services provided, including peer support, crisis assessment, case management, and the nurse assessment, are not billed to insurance, and there's no charge. I also specifically want to talk about suicide care because I think often people equate a suicide crisis with going to the emergency department. And we really want to emphasize that if someone's having thoughts about suicide or they're in a suicide crisis, we really want them to come to mental health urgent care to access supports and resources. And that could include a crisis assessment. It could include peer support, having a safety plan created collaboratively with providers and the guest, and then also follow-up assessment and follow-up care so that the stressors or drivers that are contributing to the suicide crisis can be addressed and a person can feel connected to the next part of their support or treatment journey, whether that's more mental health supports, more intensive mental health supports, or connection to other supports in the community. I also want to specifically talk about health equity. So one of the reasons that we have created this program in Burlington and on the bus line is to be as accessible as possible to all different parts of our community. I talked about the physical location, specifically reducing stigma because people can walk in for any reason. And it's part of why we're really excited that we don't need to worry about health insurance or billing for most of the services that are provided. We want it to be as easy as possible for someone to access supports if they're in crisis and needing that urgent support. In our outreach, as the program opens, we are intentionally reaching out to underserved populations across the Burlington area and Chittenden County so that we can create warm connections with different community partners and different communities to explain the mental health urgent care program, and to welcome people in to use the services. We will have language interpreters that can be called to come on site when that's available. And then at any time, we'll have language interpreters available virtually. And then specifically, I want to talk about substance use because this is a big concern in our community. So if someone is using substances and is ready to access services or wants to talk about their symptoms or connections to support, they're welcome to come in to mental health urgent care. If someone is under the influence of substances, they're also welcome to come in as long as they can manage their own person. And that means that they can ambulate if that's what they typically do, meaning that they can walk, they can use the bathroom, and they can have a conversation however they typically do that. If someone's under the influence of substances such that they're falling over, they're falling asleep, they can't maintain a conversation, then we'll help them access support so that they can safely be somewhere to sober or detox before they're accessing supports. So this mental health urgent care program is the 4th program in Vermont designed to be an alternative to the emergency department. So there's one in the Northeast Kingdom. There's a shot of the 7 Days article about that program. There's a program in Washington County and additionally one in Addison County. So we're really excited to join that group of programs providing this alternative option for people needing support. And with that, we're really excited to open it up to your questions.
Okay. Thank you so much, Charlotte and Maureen, for your fantastic presentation. Even though I've seen it a few times, I feel like I always learn something new. So thank you. We've gotten a few questions already, and I invite those of you who would like to ask a question to be sure to write it in the Q&A. And then for those of you who ask multi-part questions, I wanted to let you know we'll try to hit as many as we can. But if we don't hit them all, you can always follow up with me after. So, okay, the first is, this is almost too great to believe. So my question is, how does someone explain the situation is not suicide? And how does that happen?
I just want to focus on the too great to believe part for a moment because the space at Arnold 4 looks outstandingly beautiful. And all of the consultation rooms for the guests have views of the lake. And it does feel very exciting to have this addition in our community. So just want to focus on that for a moment. But Karen, can you ask the question about suicide maybe in a slightly different way?
Sure. So what I'm getting from this question is that what if somebody is not experiencing suicide ideation? I think that's the right way to say that. Please correct my language if I was wrong. But are experiencing, starting to experience a crisis. How would they be able to explain that to the team during their intake?
It's a great question. So I highlighted suicide as a specific type of crisis that we are prepared to support if someone comes to mental health urgent care, but there's so many different types of crises. So someone may have thoughts of anxiety, a lot of worry thoughts. They may be feeling really down. They may be feeling completely overwhelmed and stressed. The crisis does not have to be at all related to suicide. And when someone comes into mental health urgent care, they will be directed to check in with reception, just like when you typically go to a doctor's office or urgent care. And at that point, some questions will be asked about why someone has come in or what they're hoping to get. You don't have to know exactly what you want or exactly what's going on, but just to give a brief high-level explanation for what brought you into the program. And from that information, we will work with the guest to help connect them to the right supports. It could be that someone really isn't sure what they want, or they may feel embarrassed or scared to talk about what's going on. And so the conversation may start with a peer specialist or a care manager, or any different types of staff who will explore how a person has been doing recently, what symptoms they're feeling, and that may help create a relationship and the comfort to talk more about the crisis so that all the right services and supports can be put in place.
Okay, thank you, Charlotte. This next question might also be for you as well, Charlotte. But first of all, I like reading the accolades, so thank you all. This is very important, impressive collaboration initiative. Thank you in all caps. So thank you to our questioner. So the first question I have from this person is, would you please speak about confidentiality of the visits? And whether or not the notes will be part of permanent medical records. And actually, this might be one for both Maureen and Charlotte, now that I'm seeing that it's the medical record reference here. So which one of you would like to take it?
I'm happy to start.
Okay.
So privacy is very important to us, as is confidentiality. And so again, similar to going into a new doctor's office for the first time or going into physical health urgent care, part of the process of welcoming someone in will be explaining the services, and there are some intake consent forms. Part of those consent forms are the guest giving permission for the partner agencies to talk amongst each other to best coordinate and collaborate care, and it's not a required form. So if someone wants to come in and just talk to a peer specialist from Pathways, but doesn't want their information shared, that is absolutely fine. If someone is a Howard Center client and they aren't able to reach their supports in that moment, they don't know where else to turn, and they come in to mental health urgent care, they can just talk to a Howard Center clinician or case manager, and we don't have to share information with the nurse from community health centers or the peer specialist from Pathways. If we are able to have that consent form signed, then we can share information and collaborate as needed so that a guest can not have to repeat their story again and again, and can have what would feel like a seamless experience. So each partner agency, Howard Center, Pathways, and community health centers will be maintaining their own documentation in their own electronic health records. And Howard Center will have a visit summary document that will be printed and given to the guests to leave with, so they're clear about what services were provided, and then what the follow-up recommendations are, both in terms of specific next steps a guest should take, and also in terms of any referrals or next appointments. That after visit summary can be shared with ongoing providers, a primary care doctor, and the different community partners as part of this collaboration if the guest wants that to be shared.
Thank you. Maureen, did you want to add anything regarding our electronic medical record at UVM Medical Center?
I think I just want to emphasize that we have Howard Center, community health centers, Pathways, and UVM Medical Center, each with a distinct documentation system or electronic health record. And the control for how that information is shared lies with the guest or the patient. And so if the patient wants to share it, I use the word patient, if the patient or guest wants to share it, they have that opportunity. And if they don't want to share it, it doesn't get shared.
Thank you. And this may actually, you both may have already addressed this next question, but I think it's worth hitting on the nose. What would be the course of action for non-citizens or persons without documentation, which could include refugees or temporary residents, for whom having a mental health record may jeopardize their stay in our country?
A great question. There is no residency requirement to access the service, so I just want to name that. This service is in Burlington. The goal is to serve people in Chittenden County, but if someone is here on vacation, here from a different state or different part of Vermont, and they're needing urgent support, they're welcome to come to mental health urgent care. And then if needed and appropriate, we can help connect them to local resources. If there's concern, and it could be for for legal status in the country, or it could be for other concerns about having a mental health record. We will work with that guest to figure out how to maintain and protect their privacy and confidentiality while still getting the supports and services that they're looking for that day. That's the priority.
Okay, great. This may have come in before you addressed this in the presentation, but I never think this is something we don't want to underscore again. Will there be interpreter services for non-English speaking guests?
Yes, there will be interpreter services available virtually on an iPad for any language needed. We have program materials translated into more than 10 languages. And just today I was at Mental Health Urgent Care, and we have a welcome wall that has the word welcome in, I think it's 19 different languages. We are prepared to support people who do not speak English, and we really want them to come to this program, and we will provide support in their language.
Thank you. How many peer supporters will there be at one time? And is this a question that we want Katie to address?
Sure.
If you're ready, Katie.
Yeah. Hi, everyone. So we'll have a peer support team lead, and then we have 2 peer support specialists as well. And our team lead is actually somebody that's been at Pathways Vermont for a decade. So we're really excited that that person is headed over to the mental health urgent care.
Great, thank you, Katie. I might call you back on in a minute or two. I saw another question that we might need you to answer. This is a great question. Do you have drawings or photos of the space?
So the space is just coming together. Just today, a sign was put out at 1 South Prospect. And so on Howard Center's website, we will have some photos to help with directions to get to 1 South Prospect and to the Arnold entrance. It is now well marked as of today. And as I mentioned, the space is really beautiful. So we will definitely have some photos both to showcase the space, but I think also when someone can see a space that they might be visiting, that can help alleviate some anxiety or fear. And so on social media, on our website, and in print materials, we will have photos. More to come on that.
Great. Where might you refer a person needing support during alcohol or substance withdrawal?
So our supports for that in our community are limited, so I just want to acknowledge that. If someone is needing medical detox, they might need to access the emergency department. They potentially could access Valley Vista or Serenity House. If someone is looking for immediate treatment, meaning same day for an opiate use disorder, they can access Safe Recovery or the Chittenden Clinic through Howard Center, or support through the emergency department. Maureen, are there other services you would add?
Not for the withdrawal or detox services. I think you covered them.
The Addiction Treatment Center is also at 1 South Prospect. So if someone is looking for outpatient services, that can be a warm connection in the building.
Okay, how will medications be initiated without an MD on site?
So the prescribing at mental health urgent care will be very limited. If someone is coming, for example, with symptoms and it's determined through a medical assessment that they have a urinary tract infection, which can have symptoms that look like mental health crisis symptoms at times, there may be an antibiotic prescribed, and there's a pharmacy at 1 South Prospect where someone can pick up that prescription medication. For the most part, prescribing will be referred back to someone's primary care doctor. So the nurse or the medical provider, with consent and permission, can coordinate recommendations about prescribing or concerns about medical assessment back to primary care. And then the guest's ongoing primary care doctor would be responsible for prescribing. If someone doesn't have a primary care doctor, they can be connected to an in-person visit at Community Health Center. And then in that in-person visit, which could be the next day or within 48 hours, that guest and medical provider during that visit can talk about ongoing prescriptions.
Great. So our next question, thank you for this presentation. It's very informative. Did you say that there is a similar program in Addison County? And if yes, where is it?
So there is a similar program in Addison County. The structure of it is a little bit different. When the Department of Mental Health put out the request for proposal, the intention was to try a few different models across the state to figure out what the best practice is for Vermont, for Vermonters in rural settings and more urban settings. And so it's not a cookie cutter, exact program. My knowledge of Vermont geography is limited, so we can get you that information of where specifically is located in Addison County. It is through CSAC, Counseling Services of Addison County, which is the Howard equivalent in Addison County. And I'm confident information's on their website, but we can certainly circulate the details related to that to this communication.
And that specific program is called Interlude.
Okay, I think we'll all appreciate this one. And I think anybody can answer this. I'm a social worker in the community and burnout is high. How will you ensure that this is a safe and sustainable place to work?
That is a wonderful question. And one thing we've talked quite a bit about is that we want this program to be for everyone. So for that social worker and anyone else, if you're needing emergent support and you can't access an EAP or other ongoing resources, we do want mental health urgent care to be considered as an option if that is what is needed. So this is a program for all of us. And in terms of staff wellness, we have structures built into the program to provide ongoing training, ongoing supervision, ongoing consultation, and ongoing wellness activities specifically for the staff. So the majority of staff for mental health urgent care were hired 3 or 4 weeks ago at this point. They have a comprehensive onboarding training that they're moving through together so that they can be as prepared as possible and as joined as a team as possible on October 28th. And it's really exciting to feel their energy and hear their excitement about being part of this new program. But with the structures in place like supervision, training, consultation, support, and then specific wellness, and then encouraging other infrastructure like taking time off, accessing EAP or employee assistance program when needed, and accessing the supports from each other. We're hoping that that's the right recipe to be a sustainable role in a sustainable model. Maureen,
Great.
would
Did
you add
any,
anything?
yeah, I was wondering if ever any of our other panelists also cared to weigh in.
I think all I can say is that in the conversations we've been having every week over the last couple of years, the well-being of the staff has been at the forefront. When I think when everybody has walked into the space that Charlotte described, they have made a comment about how soothing and comforting it is and how the staff will benefit from it. Clearly, this is a job that needs more than just a nice environment to prevent burnout, but it will be, I think, a legacy of the program if we can, when we can, have a system where our staff have the ability to tap their own resources when they're feeling like they need it.
Thank you. And Katie, I see you're here.
Go ahead, Katie.
I was just going to add that some of the trainings that folks are doing is everybody's getting trained in intentional peer support, and a follow-up of intentional peer support is that folks will engage in something called co-reflection, where they'll process together how the work is going and what's coming up for them. And I see a few of you actually are here today that are engaged in peer support, so I'm just excited that everybody that works at the mental health urgent care is going to be trained in IPS.
Thanks, Katie. And Charlotte, did you have another comment?
Yeah, I heard the word safety in your question, and I didn't want to gloss over that. So the staff have multiple trainings as part of their onboarding in safety practices and emergency procedures, in de-escalation, and not just de-escalation, but de-escalation in a trauma-informed context, which feels really important. We have had many conversations in these early weeks about how the safety of staff, both physical safety and emotional safety, is paramount, and how that is a priority within the program. And so I think that culture will set us up for success as we open.
Okay, thank you. So, if the mental health urgent care determines someone is in danger to themselves or others, do you call an ambulance for the emergency department? And is insurance billed in that case?
So if someone's a danger to themselves or others, the first thing we'll do is have a conversation with them, if we're able to engage them verbally, about what is contributing to those thoughts, how long they've been having those thoughts. And by engagement, intervention, assessment, really a conversation, we're hoping that we can understand those thoughts and make a safety plan with the guest and connect them to appropriate outpatient supports. It could be that a referral to Howard Center's Adult Crisis Stabilization Program is needed, or a referral to Pathways Peer Respite Program, which is opening soon in Williston. So thoughts about hurting oneself or someone else is not an automatic trip to the emergency department. If it's determined that someone needs inpatient psychiatric treatment, then we will work with the guest on how they can safely get to the emergency department. It could be that they came with a natural support, a loved one who feels safe and comfortable driving them to the ER. We have the option of some staff transport to the ER when that's feeling safe or appropriate, or even accessing a taxi voucher, for example. 1 South Prospect Street is just about 2 blocks from the ER, so it may be in some situations that a guest wants to walk with a natural support or a staff person to get to the ER in the safest way possible. We will be accessing the police or an ambulance as a last resort, if that's the only way we can safely transport someone.
And I'll just add that local EMS are separate and distinct from this program. And if they charge for a transport in normal circumstances, they would charge for a transport to get from 1 South Prospect to the emergency department. But as Charlotte mentioned, our goal for using a 911 ambulance to move people is to do that when it's required for that level of care. It's an emergency transport need.
Okay, thank you. So if someone is being treated for a psychotic disorder, is having a crisis but not severe enough to be an inpatient candidate, can they access the mental health urgent care? I think either one of you can answer that.
Yes, please. Yes, so people may have symptoms of what some people call psychosis and other people call hearing voices or seeing things, or having an experience that you or I may not currently be having, and those folks are welcome to access mental health urgent care for support, which could be peer support, it could be a crisis assessment or safety planning or case management. But if someone has symptoms of psychosis, they are welcome in the program.
Right. And thank you. And this person also went on to say that they might be having an exacerbation of symptoms, but not a threat to themselves or others. And I think you were able to cover all of that in your answer. Great question. That is exactly the kind of person we hope will come to the mental health urgent care. So the next question is, my understanding is that there are often wait lists for outpatient therapists and other community resources. Um, how will that be managed for guests who need that?
It's a great question and can certainly contribute to someone's crisis when they're ready to access a therapist or they're ready to get help and then they hear that there's a wait. And that's why I'm really excited that case management is part of the services that can be offered so that a guest can sit down across from or next to a case manager who can have their laptop with them to look at different therapy resources and other supports that could be provided. And so it could mean that the case manager helps to make phone calls about finding access or availability. And there are some different local networks that share their openings or availability so that it's not guesswork about when there's a wait list and when there's not. We do have at Howard Center immediate access for therapy if someone's in a suicide crisis through a framework called CAMS, Collaborative Assessment and Management of Suicidality. It's a short-term therapy framework specific to suicide care. And so there's access like that in some other areas as well in our community, where when there's a specific issue or concern, our case managers will quickly become experts in our local system and will know where or how to get someone in. It may mean that there's a wait for the desired service, the first choice service, and other supports are put in place until that service is available. So for example, someone may be referred to the Seneca program, which is also at One South Prospect. And today's Wednesday, maybe they have availability for an intake on Monday, but the guest is really having a hard time. And it could be that the case manager helps them connect to turning point supports or other supports through pathways, or even encourages the person to come back to mental health urgent care on Thursday and Friday, and then helps them make a plan for the weekend as they wait for that intake at Seneca.
I'll just add that we're also engaging local programs and resources, certainly the various psychiatry programs through UVM Medical Center, but other resources as well, to find the smoothest way to transfer patients to the right resource. And so we hope that we will take some of the clunkiness of the system that patients and guests may experience out of the equation and make it a much smoother process.
Okay, thank you. So we have a two-part question, and I actually think we addressed the first part of it regarding acute medication management options, and I think we've addressed that. The second question is, what happens to patients who are still experiencing a crisis at 5 p.m.? Do they get transferred over to the hospital?
I'll start and I'll hand off to Charlotte. We only want to transfer guests to the emergency department who need emergency department level of care. And so we don't want it to be time-based, and we don't want it to be because, it hit 5 o'clock. When we have a guest who enters the clinic, the first thing we'll start doing is planning on what resources they need and where they'll be going next. As it approaches 5 o'clock, we will be leaning on some of our peer specialists and care managers to help identify resources in the community that are open after 5 o'clock that might serve the individual. And we'll be working to make sure that they have a safe experience for the night in the event that they want to come back and see us tomorrow, or a safe experience for the night regardless. And so by virtue of the fact that we have a time, an open and close time on the schedule, I think every single time we've done this presentation, which is many, many times, this question's been asked, and it's a great one. But we really are going to do our absolute best not to transfer anybody to the emergency room because of time, and only because of the level of care that they need. Charlotte, would you add anything?
No, well said.
Okay. Thank you. So this next questioner actually asked me to attribute this question to him. So this question is from Dan Toll from Parker Advisors. And thank you, Dan. I think this is a great question. So many of us peers with lived mental health experience who are in crisis that includes suicidal ideation are leery of engaging any traditional, in quotes, and that means medical model, provider types, and this includes a mental health urgent care, a UVMHC. I'm not sorry, I don't know what that is, Dan. For fear of forced medication or forced incarcerative lockup. Please reassure me that I and my clients in crisis can come to the mental health urgent care without ending up being involuntarily medicated or hospitalized. And I should have said when I started this question that, this is for you, Charlotte and Maureen, and if anybody else would like to weigh in, I think this is a good one for us to address together. Thank you. And thanks for the question, Dan.
Yeah, thanks, Dan. So we in the mental health urgent care program have engaged Pathways in a whole set of trainings for all of the staff on alternatives to the traditional mental health system, and also understanding the harms that have occurred in the traditional mental health system. We are really excited to offer alternatives to the traditional mental health system while we work to be trauma-informed and person-centered and undo the damages of those harms historically over hundreds of years. So if someone wants to come up to mental health urgent care just to see it, that is absolutely welcome if that's going to help them figure out if that's a support that they might need to access in the future. If someone wants to come into mental health urgent care and only access peer support through Pathways, that's not only welcome, it's encouraged. And in terms of involuntary medication, there's no involuntary medication given at mental health urgent care by any of the staff at any point. The only medication that will be on site at mental health urgent care is over-the-counter Tylenol, for example, if someone has a headache, and that could be staff or a guest that comes in. In terms of involuntary treatment, in our system, that is an absolute last resort. And within mental health urgent care, there are two key factors that feel really important in thinking about voluntary services in a person-centered way. The first is that we're a voluntary program to begin with. So as Maureen mentioned, an ambulance can't bring someone, or maybe I mentioned this, but either way, an ambulance can't bring someone to mental health urgent care. And while the police could potentially, if they're available and feel it's appropriate, give someone a ride to mental health urgent care, the police can't bring someone in handcuffs. So someone has to arrive at 1 South Prospect, go through the doors, go down the hallway, go up the elevator, and go into mental health urgent care to access support, which means that they're there for some reason to think about how their symptoms could be alleviated or to access help of some kind. And all of that is driven by the desires, needs, and wants of the guest themselves. The providers there will make recommendations about different types of supports. And if and when there's a really serious concern, I think the other beauty of the model is the value of time. So we don't have 1 hour guest sessions scheduled through the time that we're open. If someone needs to sit with a crisis clinician and a peer specialist to talk about maybe their thoughts of hurting themselves and what the different options are, that may take a number of hours to figure out what can be the plan from here that feels right for the guest. And so I think with both the voluntary nature of the program and the value of time with the interdisciplinary staff, we'll be able to work towards figuring out the voluntary services and supports available. And again, when inpatient treatment is recommended or desired, we will help get the guest to the emergency department because they're looking for that level of care.
I think the only thing I would add, and I don't remember if we said it this evening or not, but you've noticed Charlotte, Charlotte's much better at it than I am, but Charlotte and I using the word guest And that's one of, while it's a subtle difference, it's a mindset difference in who we're welcoming into the clinic. Where we are trying to differentiate this from a traditional medical model and an alternative to an emergency department setting. And so the guests that will be coming to the clinic will be guests of our services. And everything Charlotte described will be the experience we expect them to have.
I also don't want to be naive to Dan's question in that if someone is physically violent or making serious threats to the livelihood of the people around them, meaning if someone brings in and wields a weapon, we will be calling 911. We are expecting that the people in the program, guests and staff, can be there safely. So if someone is actively violent, we'll be making sure that everyone in the program can be safe. Similarly, the staff of mental health urgent care are mandated reporters based on their roles in the state of Vermont. And so if someone is making specific threats to harm a child or to end someone else's life where they're showing intent and means to do so, we will need to intervene again to ensure the safety of others. If someone's having thoughts without the threats and can have a conversation about it and engage in safety planning and treatment, again, we're really excited to engage with those folks and help them engage in different services if that's what they want. And that may be the reason they came to mental health urgent care.
Okay. Thank you very much. So the next question is, I assume you'll be collecting data on the mental health urgent care. What data will you collect and for what purpose?
It's a great question. So we will be collecting data to show our outcomes, hopefully to show our good outcomes, but also potentially to show not good outcomes so that we can figure out how to pivot our services or advocate for more funding or create different programming. So some of the data collected will be demographic data, like the age of the guests, potentially the towns that they're coming from. We will be asking guests to share if they have health insurance so that we can figure out beyond the 3 years of funding, if we were billing, what revenue the program would generate through health insurance so that we can help figure out financial sustainability for the program beyond the 3 years. All of the outcome data that we have will be de-identified, meaning a specific individual cannot be determined from the outcome data. And when a number is really small, like there are only 2 people of a certain demographic category, we wouldn't share that information. We would keep that private and confidential. And so some of the outcomes may be how many people are accessing mental health urgent care and at what time of day so that we can figure out the staffing model. Or that we can see if we can demonstrate that we are making an impact on the emergency room volume, which is ever changing for so many different reasons. So we're really excited to collect outcome data. It will be de-identified and we'll be sharing it again in a de-identified way with stakeholders, with the community, and with leadership of the partner agencies so that we can figure out sustainability for the program.
Okay. Thank you. And Dan wrote in again to say, I'm assured, thank you. So thank you, Dan. That was a really important question. So another question for you is, will you allow therapy dogs to spend time at the mental health urgent care?
That's a great question. So service dogs are of course welcome and therapy dogs are welcome. We aren't able to welcome pets, but if a dog is working, meaning a service dog or a therapy dog, they are welcome.
Great. And this question might be for you, Katie. In consideration of staff burnout and peer support specifically, I'm also wondering if there are thoughts on how to support peers working on an interdisciplinary team in an ongoing way, in addition to everyone attending the IPS training. That piece is awesome. So
Yeah.
did you catch all that, Katie?
Yeah, thanks for the question. I think, well, IPS and having everybody trained in IPS, I think will give peers a tool to actually engage with everybody else on the team in a way where everyone's using shared language, which I think is really important. I actually was part of some of the trainings that Pathways is doing at the mental health urgent care right now. And I think everybody's bonding in this amazing way where there doesn't really feel like there's this us and them, which is sometimes a worry for interdisciplinary teams where you have a peer on the team and you want to make sure that they're not feeling tokenized in their experience. So I feel like setting the tone for this team already, we're really leaning away from, I'm not feeling a fear around that, which is really amazing. Another part of this is just that the Pathways staff that are hired will also have the support of Pathways Vermont. So there will be a lot of opportunities to engage with other peers as well.
Okay, great. Thank you, Katie. And this is a great question because we did have to spend a lot of time talking about holidays. So Maureen or Charlotte, I think either one of you can handle this. But the question is, will you be open on holidays? And if not, how will people know what days you are closed given different agencies observing different holidays? So you all ready for it?
Yes, this has been a big discussion, and so a decision was made that we will be closed on holidays. And ultimately, with Howard Center as the lead agency, we decided to follow Howard Center's holiday calendar. And so holiday closures will be posted outside of and in mental health urgent care, as well as on Howard Center's website and in social media, so that people are aware in advance of the holiday about the upcoming closure. And when mental health urgent care is closed, first call for Chittenden County, as our mobile crisis response and phone support is available, as of course is 988.
And I will just note, because this was a big part of the discussion. So the mental health urgent care is in the same space as many of the UVM Medical Center's outpatient clinics. And as it happens, our holidays align with the days that Howard has their holidays. So it wouldn't be that somebody's coming to a building and finding that, oh, only the mental health urgent care is open. So just wanted to clarify that was one of the things that one of the many things that we had to negotiate as a four-partner collaboration. Okay, so Charlotte, I think this question is for you. Is Assist still available for a crisis respite stay? And could something like that be coordinated in a mental health urgent care visit?
That's a great question. So Howard Center now calls the Assist program our Adult Crisis Stabilization Program. It's located on Pine Street, and it's a 6-bed program, meaning 6 people can be there at a time for crisis stabilization or respite, depending on their needs. And typically people are there from about 3 to 5 days. It's a voluntary program run by Howard Center. And so right now, referrals to adult crisis stabilization come from first call for Chittenden County, or if someone has a Howard Center case manager, they can make that referral directly, and mental health urgent care will be able to refer someone to adult crisis stabilization.
Katie, we've got another one for you. If someone arrives at the mental health urgent care and only wants to access peer support services, will peer support specialists need to assess for safety or to self or others? If so, what would this look like?
Yeah, so if people want to come and only engage in peer services, that's totally fine. And like Charlotte said earlier, even welcomed. Everybody is going to be trained in either alternatives to suicide or when conversations turn to suicide. And I feel like that's a little bit more of a, I don't know, like just a different approach than some folks are used to. So that's kind of the approach that we're taking in these conversations. With peer support, we don't do assessments. So if something came up that was concerning, I think that we would talk with the team and see what we wanted to do, but we don't do assessments, and we would just try to keep it as much aligned with peer support as possible.
Karen, you're muted.
We knew that had to happen at least once. So I was just starting to say, thank you, Katie, was the first thing I said. And the second thing I said was just that we've gotten a little bit more love in the Q&A. And so one anonymous attendee said, this is how all healthcare needs to work in our community. So thank you for saying that. We're really proud of this collaboration. The next question is, can the mental health urgent care serve Vermonters residing outside of Chittenden County? Thanks.
Yes. The goal of the program is to serve residents of Chittenden County, but we would welcome people from other counties in Vermont, from who are visiting here from out of state. And so you do not have to prove Chittenden County residents to receive services at mental health urgent care.
And that includes college students, which is a population we are expecting to serve and excited to serve as well. So we'll be asking someone's demographic information, including their address and phone number, but the answer to those questions won't have any bearing on the services provided.
Thank you. So the next question is, how will you handle homeless individuals who come into the mental health urgent care? Could you please discuss this? Is actually the question.
The same way we would be serving any other guest who comes in. So we'll be talking to them about their needs that day and their hopes for services through mental health urgent care. And if housing or their homelessness is a particular concern, we will be talking with them. And again, that could be through a crisis clinician, case management, peer support, about their specific experience and what help may look like. That could be assistance connecting to a housing application or help completing a housing application. For some guests, that may be identifying resources for a tent or a shower or the local food shelves in the community where they're sleeping. So it really depends on the specific needs of the guest and what they're coming in for help that day. Maureen, would you add anything?
I was just going to say, I wouldn't add anything operationally. I was just going to say with compassion and respect.
Well said. So we're kind of starting to wind down on our questions. So if anybody else has a question that they would like to have answered, please feel free to add it to the Q&A. But in the meantime, I have another one for you all. So are there specialists on staff who can appropriately assess and treat people who are impacted by global turbulence, who may also have experienced war and violence?
Yes, we have a couple staff members who have experienced war and violence from different perspectives in their growing up. So they may share their lived experience if that is helpful and appropriate. And we can support people with their symptoms of trauma or unease, depending on what they're presenting with, and then help connect them to specific supports and treatment in the community.
I think I would just add that we also recognize that there may be some specialties, subspecialties that this population might need. That could be geriatric services, it could be various trauma related services, and we'll absolutely rely on our community partners who do specialize in those things if it is beyond what we are able to provide. The team that Charlotte and Katie and Community Health Centers has assembled is amazingly diverse and excited and skilled, and they're not going to be everything for everyone. And so we will rely on the expertise of our community partners. This is a collaboration beyond just the 4 partners who have been named.
Oh, we might have one more question. Let me just see. You can take a breath for a sec here. Okay. This might be one of our last questions. So, do you have any plans for collaborating with schools if they observe children are impacted by parents' mental health needs?
That's a great question, and I've talked to some children-specific providers and youth serving agencies about having information about mental health urgent care on hand to give to parents. So while we are an adult serving program, we know that many adults are in the context of families and our parents or caregivers. And so we will work to get information not only to schools, but also to libraries and primary care and pediatric offices so that adults have the information about accessing the service. If a school provider is particularly concerned about a parent, they can absolutely give the parent information about mental health urgent care and encourage it to be accessed.
Okay, we're getting some more love. I just wanted to say thank you to you all. We're lucky to have thoughtful, knowledgeable, and caring providers here. Excellent town hall. Thank you to all, including the awesome Katie Bork. No specific questions, just to thank you on behalf of Lund. We are so grateful to all agencies that are part of this model, and we're looking forward to working to collaborate to meet our community's needs. Thank you all so much. Okay, we've got a couple more questions. Does follow-up need to be in person, or will you provide any case management follow-up by phone?
So follow-up could be in person, or it could also be by phone. It could be a phone check-in or an update about the status of a referral, or it could be care coordination. So yes, absolutely follow-up can be by phone.
Great. Will you be talking with the friend or family member who brings the person to the care center? They have their own crises too.
Absolutely, that's really important. So if the guest wants that friend or family member to be part of their services, we welcome that. Our consult rooms are quite large and can fit a family or a small crowd, depending on who a person brings in as their supports. But beyond that person participating in the support or services for their loved one, who we're calling the guest, that person may need their own support as well for their own experience. So we will absolutely be engaging that person and offering that if it's desired.
Okay. And we also just got a thank you to all on this call. So I think, oh, no, sorry. I thought we had our last question. I think I'm gonna call it, this is the last question for sure. And then I think we'll wind down. So how do you hope to care for individuals looking for withdrawal from alcohol or substances?
I think it depends on their level of use and what kind of withdrawal support they need. So if they're needing detox, it will likely be a connection to the emergency department or referral to Valley Vista or Seneca. It could be a connection to Turning Point or other outpatient community services. Maureen, would you add anything?
Just that, and I think that I want to echo sort of the sentiment that Dan relayed earlier, is these are services that would be offered voluntarily to the guest who is seeking themselves to withdraw or to detox from substances. And we want to act as sort of the traffic cop to point them in the direction of the resource that might best serve them and have capacity and availability. We recognize that we have a knowledge set that the sort of lay public does not have on what programs have capacity, what programs specialize in certain substances or certain circumstances. And we want to connect the dots for people, especially when they're in a position where maybe they're having difficulty navigating their own day-to-day living.
Okay. Well, thank you all. Like, what makes for a good webinar are really good questions from the group as well as presenters and panelists. So this was a great collaborative effort to make this webinar really engaging. So thank you all for being with us tonight. And I also want to thank, obviously, our presenters, Maureen and what's your name, Charlotte? There we go. This is why I should not be the moderator. And also thank you to our panelists who were on the ready to answer questions. And Katie, thank you for jumping in so many times. And a special thank you to our ASL interpreters, Hannah and Lucia, you were fantastic. And then just so that our audience knows, you are all welcome to join us for our ribbon cutting ceremony and open house, which is on Monday, the 21st from 3 to 7. We'll have a brief program starting at 3:15. And I think all of the people that you've seen on this screen are going to be giving tours. And so we welcome you to do a walkthrough with us. And just a reminder that the recording from tonight will be available within a few days at howardcenter.org. And with that, we will say farewell and good night. And thank you all.